So sort of now we're going to end with the second line approval of Tarlatamab for extensive stage small cell lung cancer, as I mentioned, for extensive stage small cell lung cancer, where the small cell lung cancer has sort of metastasized beyond the lungs. Our typical first line treatment is based on chemotherapy with immunotherapy. And then following that, we have a few chemotherapy-based options, and with the advent of Tarlatamab, I think it provides us with another option, which is sort of more immune targeted. So this was based on the Delphi study, Delphi 301, which was presented again by Dr. Passares in last ESMO. And really, this was phase 2 study where they tested two different doses of Tarlatamab, 10 milligram, 100 milligram. This was obviously succeeding one of the studies that did show some efficacy in small cell lung cancer in some of the phase 1 studies, specifically for the Tarlatamab drug. And so, Fauzi, tell us a little bit about the overall response rates and what your thoughts are in the efficacy on this and this drug.
Absolutely. So, as you said, this is a group of patients whose cancer has spread outside the lungs. And for this particular study, they included patients who received one or more line of treatment before going on this particular study. So a very resistant or a very tough disease, because it has actually progressed through multiple lines of therapy. So in phase 2, the first thing we look at is how is the response rate? How did the cancer respond? Did it really shrink? Did it grow? Did it stay the same? And this all constitutes what we call the overall response rate, or ORR. Now, they try to compare two doses of Tarlatamab, 10 milligram and 100 milligrams. And actually, the response rate was higher in the 10 milligrams. So this is ended up the dose being, studied further, and in the dose expansion and other phases of this study. So it was 40% in the lower dose compared to 28 or 30% in the higher dose. When we were also conducting a phase 2, we look also at the progression-free survival and the overall survival, and they were kind of comparable between the two doses. But more importantly, we have to look, because we're looking at two doses, we have to look at the side effects, and it was slightly higher or a little bit higher in the higher dose of the drug. So that's why they ended up selecting the lower dose, which is 10 milligram, for the dose expansion and further studies of this drug. Tarlatamab is a unique drug in its mechanism of action, where it binds in one arm, binds to the cancer cell, and the other arm it binds to the immune cell or the T cell. So bringing them together can induce or cause a lot of inflammation. So that's why we start hearing about something called CRS, or cytokine release syndrome, which is basically an inflammatory reaction, and it's a unique side effect profile for this type of medications, what we call BiTEs, or bispecific T cell engager. And we're all hospitals right now are trying to implement processes on how to infuse this drug and also how to deal with the side effects.
Absolutely. So as Fauzi mentioned, again, this drug has been granted accelerated approval for use in extensive stage small cell lung cancer. And there's obviously some logistics that we have to figure out, especially given the first couple of doses have to be infused, and then patient has to be observed for 24 hours. So there are most centers right now, at least, are hospitalizing the patient for 24-hour observation. But again, this offers an excellent option for our patients, specifically who have experienced tumor progression after chemoimmunotherapy for their extensive stage small cell lung cancer. So I think we covered a lot today. And again, thank you, Fauzi, for being on this panel with us and really going through some of this data. Here I have the key conclusions that are summarized. I'd love to have your closing thoughts for our audience.
So I think these are all great options, very good advances in non-small cell and small cell lung cancer. Most of these are practice changing in some way. But when we're talking, let's start with the EGFR mutated non-small cell lung cancer. Now we have three different first-line options, and I think they're all valid. I think they're all great. But it's all about discussion between the patient and their doctor. And in my practice, at least in my mind, I have certain group of patients where I would consider one of these or recommend one of these first line options. But again, it's all about discussion between the patient and the provider, because each one of them has a unique side effect profile. Second line, I think I'm very happy to see that amivantamab plus chemotherapy is approved. I think it's a great option in the second line after patients or after the cancer progresses on osimertinib. And the LAURA, which is post chemoradiation, is actually a great study. And we're all expected this study to be kind of positive, and also for it to be approved. In terms of ALK, where we're all very impressed with the lorlatinib data, it's practice changing in some ways for some patients. And again, it's all about discussion, because alectinib, the other option, is still a very good drug, relatively well tolerated. And lorlatinib is also well tolerated. So it's all about a discussion between the patient and their provider. And the two studies that we discussed in small cell lung cancer, in my opinion, they're practice changing, and we've been waiting for such options in small cell lung cancer for a while now.
All right. So again, on behalf of the audience, I would like to thank you for your time, Fauzi, and we hope that this was educational. And thank you again for Cancer Grace to let us do this and spread awareness on some of the treatment advances in non-small cell and small cell lung cancer. Thank you.
Absolutely. Thank you.